Hello, good evening, everybody. This is the first webinar on our journal club, thanks to the initiative of our trainees committee. Thanks for Fani to kind of pushing us and make it happen. Thanks to our technological background, and I hope that you all are excited as we are. Tonight, we thought we start with two parts. There's the first part covered by Peter. Peter Seiler is a trainee in my department. We both work in Germany, in beautiful Saarland area, which is next to the French border. And we're sweating a lot actually at the moment because of the weather. But anyway, I'd like to pass over to Peter how it developed that we looked at a particular paper. And here's some background information for all of you, because as we go along, there might be some questions popping up in your mind. Please try to write it in the F&A, the questions and answering section of this Zoom meeting. Otherwise, we always will look at the chat to see whether there are any reactions at all. And with this, I'd like to hand over to Peter.
Well, thank you, Professor Fogg. You already introduced me, and we as the trainees, we wanted to do a journal club where we as trainees present a somewhat recent publication. We are mentored. I, in my case, was mentored by Thomas Falk. And for us trainees, it is a great opportunity to learn a bit more about the science and to teach you what we learned during our read in those webinars. So let's get into it. I would like to talk about this study. It was published in Regional Anesthesia and Pain Medicine, and its title is Efficacy of Iliopsoas Plain Block for Patients Undergoing Hip Arthroscopy, a prospective, triple-blind, randomized, placebo-controlled trial by Christian Jessen and his colleagues. It's a Danish working group. So why did we pick this study? Well, there are three reasons for it, and I want to show it to you. First one is this study is somewhat recent. It was published in January 2025. The next thing is this journal club is a learning opportunity for me as well. And I read this title, I read a triple blind study, and I didn't know, well, what's up with this methodology. And the last point is, well, it's a hip study, and I must make a confession. I like hips, and I'm betting that I'm not alone in this. So I took this study and went to Thomas Falk, the head of my department, and I asked him, well, can you show me how you read this paper? And he was like, yeah, sure. And the result of this we will present to you. But before we dive deep into the paper, there are three things we want to highlight in advance. I've highlighted them here. First, I want to explain a little bit about hip arthroscopy. Then I want to tell you a bit more about the iliopsoas plain block. And then we want to give a high-level overview over the methodology in this study. So hip arthroscopy is quite a new operating procedure, quite a new surgical procedure. It's a hip, it's trendy. There are a lot of publications popping up for it, but there are not that many centers offering this kind of surgery because it's quite a novel technique. We don't really know how painful this procedure actually is. But one thing that we do know is the patient population is typically young and healthy. Okay, so what is this iliopsoas plain block? This iliopsoas plain block, and I'm hoping you can see those two pictures, or maybe you can see my mouse. This is the um, superficial anatomy. So you see you have the ultrasound probe a little bit below the pelvic bone. Here you see the crater trochanter, and underneath those two muscles, underneath this sartorius, iliopsoas, and rectus femoris muscle, there is the head of the femur, which you can see in the anatomical cross section on the right here. You have the head of the femur, you have the anterior pubic ramus, the iliopsoas muscle, and the sartorius. What we do, or what we want to achieve by this block, here you see the ultrasonogram of it. On the left side, the native one, on the right side, the colored and annotated one, is we want to do an injection underneath the iliopsoas muscle above the capsule of the knee, above the membranous hip capsule above the head of the femur. So typically you approach from lateral through the sartorius or rectus muscle, through the iliopsoas muscle, and then you put a small dose. The studied volumes are 5 to 10 milliliters of local anesthetic there. One thing about the study that we will see is they had a quite standardized approach to this. So all the blocks were performed by the principal investigator, by one person. When we talk about a hip capsule block, blocking the nerve branches innervating the hip capsule, you probably have already heard about the Pang block. The Pang block is a block where you inject your local anesthetic underneath the tendon of the iliopsoas muscle on the pelvic bone. Whereas in this case, and this picture highlights the difference quite nicely, in the iliopsoas plain block, you inject just above the ligamentous part of the iliopsoas muscle, just above the hip capsule itself. Okay, so talking about the methodology. I guess placebo-controlled trials are somewhat familiar to the most of us. One patient gets a true drug, a true local anesthetic, whereas the other patient receives a placebo, in this case, a sham procedure, so a true injection, but the medication given was normal saline. The next thing is the patients were randomized, so they a computer algorithm sorted them in either the local anesthetic versus the saline medication. And then there is the blinding. Typically, medical studies or the higher quality medical studies provide a double blinding. So you can either blind the patient. If you do a drug study, you don't tell them if they receive a placebo or a true drug. And then you can also blind the performer or the caregiver. You don't tell the doctor as well if they are injecting a local anesthetic or if they are injecting normal saline. With this blinding, you want to reduce a bias. So if the doctor knows, well, there was local anesthetic injected, they might have the bias to give the patient a little bit less opioid. With this blinding, you can remove that. This trial is triple blinded. And in triple blinding, you do blind the outcome assessor, the statistician, the one measuring the pain in the post-op unit as well. They don't know either. And then there is another thing that I learned, which was quite new to me, that Professor Falk taught me, and I want to hand over to him what the methodology of this study and the Declaration of Helsinki have in common.
That is that is something I guess you all know. Everybody knows the Declaration of Helsinki. Is that right? I know you can't answer right away, but the first declaration of it was during a gathering in Helsinki by physicians in 1964. And of course, the declaration, if you'd now have to say what it is about to do good medicine, about to do how to behave, how to do even trials, how to do scientific work with patients. The last version has been published in December last year, and it is printed, or you can download it from the JAMA. I think they've actually presented it in January. And it has 37 chapters. It's not just doing good. And if we look at chapter, I think it is 36, no, it's 35 here, we've looked it up, 35, it says that medical research involving human participants must be registered in a publicly accessible database before recruitment of the first patient. That is kind of one of the regulatories that are absolutely necessary. And all reviewers for journals nowadays check it. Because if you submit a paper to a decent journal, the reviewers check whether it has been registered. And in this case, in the current paper we're presenting, it has been registered in a European publicly accessible database. And I checked it, of course. And the dates are there. It was 15th of January 2021. And the whole plan, the whole idea, the definition of the primary outcomes, the number of patients they needed to show a difference, what was their procedure, exactly written down so that there is, as good as one can say, no chance to alter things, kind of to in the end present something different than has been planned. And that is so important. It is kind of hidden behind chapter 35 of the Helsinki Declaration to be scientifically rigid and sound and trustful. First patient in, as you can see there, it was on the 1st of April 2021.
Okay, so what did they actually look at in this study? They looked at the consumption of intravenous morphine equivalents during the first three post-operative hours. And this is, we can say, quite an unusual primary outcome in studies. And there was another thing that I've never heard about that I've learned during the prep work for this journal club. And it has to do with this publication. So, Thomas, may you explain a little bit more about this?
When we try to look at many data, many different works, many results of people who've published their results, we still face a lot of problems with it because primary outcomes are so huge and so different in many trials that it is extremely hard to condense them, particularly when it comes to the work of meta-analysis, to combine different trials. And there is this group, it is a famous one. They've gathered, I think, now the third time. This is their second publication on the standardized endpoints in perioperative medicine, where they said it is important to look at some exact outcomes. And this is what they thought is important when it comes to perioperative medicine. And I look at it very, very critically because I must admit that I do not think that this result um, uh, is fair as far as anesthesiology is concerned, because most of them are anesthesiologists. You may see Henry Killet, the godfather of fast track surgery, on the list of the authors. And they're all well-known, beautiful, fantastic, scientifically sound people on this board. However, patients' experience is something different. And in my view, in my daily kind of reception of my work, it's not at 12 hours where I look on things that I think are important for patients. I've wrote an article once called the anesthesiological radar. And most anesthesiologists I know, they have their radars or their perceptive field of the everyday practice at least to the recovery room. That's where they exactly know how people are, how they do after what you've done. Example, once you've done a block, you want to see in the recovery room, how is the patient doing? And that's not 12 hours after the block. It's it's also, I think, a little bit unfair knowing that a single shot block cannot last 24 hours. It is impossible. Some trials use it as a standardized primary endpoint, pain at 24 hours after a single shot block. I am still not happy with it because no block lasts 24 hours. And many of the meta-analyses use this as a primary outcome. On the other hand, if these scientists think that whatever we do within the recovery area is irrelevant to patient comfort, I strongly disagree to that. So they do not mention opiate consumption at all as a relevant patient, as a standard that should be reported. And unfortunately, the trial that we're discussing today has opiate consumption as their outcome. And the early phase after a block is important. That is, I think, where we see effects. And I believe it is relevant for patients too. But I want to make sure that this is kind of a discussion that's ongoing. And if you think in the same way, this should be, I think, a little bit more discussed more openly, that primary outcomes 24 hours after a block is useless in my eyes. Thank you.
Okay, so the secondary outcomes that the investigators looked at, I want to abbreviate it. They looked at quite a lot of them. Here is a not complete list of them. So they took pain scores at rest and during movement, during the entire post-operative care unit phase every 30 minutes. They had a quite rigorous quadriceps strength difference measurement. They did not guess it. They had a proper rigorous testing for it. And of course, they looked at PONF. So, what did they do statistically? So, there was another learning point for me. They did an unpublished pilot study. They tested at 16 patients their prior hypothesis, and they found in those 16 patients that they have a reduction of around 12 milligrams of morphine equivalents. They used this as a basis for a power calculation, where you want to find with a significance level of 5% and a probability that if there is a difference, you detect it of 90%. They calculated how many patients they need to include in their study. So the amount of patients included in this study does not come from thin air, but was derived in a transparent and scientifically rigorous procedure. Um, and they came there to the conclusion that they needed a minimum of 44 patients. They planned for 60 patients because of dropouts and a nice round number. But I think we can conclude that, to abbreviate it here, that their statistical plan was indeed rigorous and scientifically sound. So, what did they get in this study? As you can see, they included 49 patients in this, and I want to abbreviate about the patients. It is what we already know. The patient population is young and healthy. And then there is another thing that was a learning experience for me as well. I've seen those three diagrams. Maybe Professor Falk, you can chime in a little bit here. This
Yeah.
also seems to be a publication standard, right?
Yes, it is. That's also important. Publication standards. If you want to look them up, the Equator Network gives a detailed summary of what kind of data are expected to be presented and given in any type of design and study, be it therapeutic or diagnostic or whatever, and reviewers look at it. This is kind of a standard that needs to be clear, and it shows more than just a figure. See how much work they've done. They've assessed for eligibility 143 patients, and they were only able to randomize 50. That's that's important because you can believe that is reality. See, if you screen 50 patients and can include 50 patients, this kind of trial looks a little bit strange. It is unbelievable. And given reasons for exclusion of patients is a necessity, not that you really dive into language problems. It gives the impression to the reader and those who need trustful data, yes, that seems kind of a reality that is improving trustfulness of the presentation of data.
Okay, thank you. So their primary outcome, I've put you the graph that they put in the publication here as well. And I think just from eyeballing, we can see that the patients receiving the active iliopsoas plane block do fare with less morphine equivalents than the patients receiving the sham block. In raw numbers, the median amount of morphine equivalents is 10.4 versus 23.8, which is an absolute reduction of 13.4 milligrams of IV morphine equivalents. Okay, how do you feel about this? Just to tease the discussion a little bit, this result is statistically significant. But is it clinically relevant? Do you care if a young and otherwise healthy patient needs 13 milligrams of morphine equivalents more or less? Just a little bit to ponder. Okay. Here, the secondary outcomes, just to abbreviate it, there are no statistical differences in any of the measured secondary outcomes. This chart here shows us one of the secondary outcomes. The others, PONF, motor weakness, they were all not statistically significant. They could not detect a group difference. Here is the postoperative pain shown. And Professor Falk and I, we want to direct your eyes to something that during my first read through this paper, I didn't see, but Professor Falk, of course, did see. Maybe you want to explain what you see here.
That's kind of data that you can, I think, immediately pick up. Imagine you'd be in the recovery area and you have a new patient coming in right from the OR and ask him, how is your pain level? And in this trial, patients entering the recovery area look at their mean pain levels. A mean pain level of 6, a mean pain level of 5, a mean pain level of 7, in my eyes, is unexpected. Because in my daily practice, we, we do not expect to begin pain treatment in the recovery room. Even if we have remifentanil as our standard intraoperative opioid, we always give an overlapping opioid. We always give systemic analgesics so that people will not arrive in the recovery area in pain. And you see that more than 50% of these patients arrive in pain, in relevant pain in the recovery area.
Just to clarify here, the study protocol involved non-opioid pain medication for every patient, but they, as far as we can tell from reading the paper, they used a remifentanil-based analgesia intraoperatively, and they did not routinely apply an overlapping opioid. And as Professor Falk told you, at least for us two, this does not reflect our clinical practice. To put this publication into context, maybe I will present the first slide for this. Professor Falk and I, we did not talk about those next two slides. But Professor Falk did a meta-analysis light. He skimmed through the literature that he found about hip arthroscopy, and we found 20 randomized controlled trials. Just to give you a baseline here, the baseline pain that the patients face is typically at around 3.8, with a range from 1.7 to 6.3. And if we have a look at the pain levels in the trial that we are discussing now, those pain levels are definitely on the higher end of what the literature reports. The patient age, well, it's a young and healthy patient population undergoing hip arthroscopy. In the available studies, in the available randomized control trials, 18 of them assessed general anesthesia as the main anesthetic method, and the compared blocks were the PENG block, the iliopsoas plane block, a fascia iliaca block, a psoas compartment block, and a quadratus lumborum block. Maybe you will talk a little bit more about the primary outcomes of these randomized control trials.
Yeah, that's a major problem, as I've already alluded to, when it comes to standardized endpoints. And it is even more confusing when you look at all what is published in these randomized trials. There is a percentage of pain in the PACU, percentage of severe pain. There is the problem that I've already alluded to with the 24 hours. They've had the primary outcome 24 hours, pain levels 24 hours after surgery. Some used NRS at discharge, whenever the discharge was. Some used the morphine equivalents within 24 hours, and that's only a kind of a selection. There's hardly any primary outcome the same in all of these 20 trials. So how can you combine the information or the feeling that also surgery is not always the same? You've seen that some start with a high level, which may reflect some higher um, pathology within the hip, in which the effect is not an absolute, maybe it is a relative one that is important. And I thought, well, maybe we look at the recovery area again because it is about blocks. Um, the blocks that I did not mention but had an influence is the blocks that the surgeons do if they infiltrate the capsule. So a LIA, a hip LIA is effective and has also been compared to other blocks like the quadratus lumborum or any of the others that you've seen on the slide before. But if you want to have an impression, though out of these 20, the resting pain levels in the recovery area is given in only 8 of these. And if you look at the mean, just no other statistics, just to make it very simple, no adaptions, no standard mathematics, but just the mean, those with the block are in the order of 3.6, and those with no block have a little bit more pain at rest, 1 hour in the recovery area. And when I dived into these, I curiously saw that those trials who were published by surgeons are less effective for a block than those who were published by anesthesiologists. On the other hand, the trial that we were discussing today had the primary outcome of morphine equivalents in the recovery area. And out of the trials that have data, the 7, the block group had around about 15 milligrams of morphine in the recovery area, and those without a block, 3 milligrams more. So if one would dive into into data, I think, also into other trials, into randomized control trials, I did not look at the quality. I did not look at proper standard methods, but just gives you the impression that if there is an effect, yes, it is there with a block. It's unclear which block is best, but the effect is not going to be how should I say, very, very, very effective. The effects are there, but I do not expect it to be as a sole component an absolute must, and will not probably change everybody's mind. It's not in my personal opinion, because I think everybody deserves a block, whatever block it is, because in the balance, risks and benefits, even the small benefits in my eyes, is really worth doing because the risks are so low.
Okay, thank you. So we want to leave you with a short conclusion on our term. First, we need to congratulate those authors. This study is a prime example of a job well done. This study proves excellent scientific craftsmanship. They provide us with great standardization. So in the grand scheme, in the landscape of hip arthroscopy publications, this study is definitely not useless. But there are 2 things we want to highlight here: standardization versus generalizability. If you have your primary investigator performing all the blocks, do the results of this study really generalize to the unselected hip arthroscopy population? If Professor Vogt, who has done way over 5,000 blocks in his life, performs those blocks, Are the outcomes the same if I, with about 100 blocks, perform them? I guess not. If you need to screen for 150 patients, but only look at 50, what about these other 90? We do need to treat them as well. So, where do we stand on this? And then there is the discussion of statistical significance versus clinical relevance. It is an ASA1 to ASA2 patient population with normal BMIs, with a young age of around 36 to 13 milligrams of morphine equivalents matter. Well, in our 95-year-olds, ASA 3 to 4 with a urinary sepsis in the beginning, neck of femur fractures, 13 milligrams morphine equivalent, they might have quite a lot of clinical relevance. But do they in this patient population? Just some things for you to ponder on. That was our presentation. Thank you for listening.
So no questions in the chat, in the questions and answered. Did they use spinal? No, they also used general. Here's the link for the trial. And this outcome, morphine use. Actually, when you compare this outcome to, let's say, a pain scale, for pain scales, there are roughly 25, 30 trials trying to find out what is relevant, what is a relevant difference when it comes to treatment, which is good or bad, relevant. That there are minimal clinically important difference trials that are there, but there is no single trial telling us what is the minimal clinical relevant difference in morphine equivalents in this setting. There is no trial. It is set. Okay, here's a rule about adjuvants like dexamethasone. Dexamethasone is a standard. Everybody should receive dexamethasone. It doubles the length of the effect of a single shot block. So if a single shot block lasts 8 hours, you double it with dexamethasone. And my standard is 8 milligrams. And even if theirs are a little bit bigger, I give 12. But it prolongs, we know that it prolongs the block, it roughly doubles it. So that
And
means 16 hours instead of 8, but still not 24 hours.
And in this study that we discussed, every patient received 8 milligrams of dexamethasone as part of their protocol. Dexamethasone intravenously, yes, you are right on that.
No, there's no evidence for 12 milligrams. No, that's just out of my gut. No, there has been trials with even more. They couldn't find a difference between, I think it was up to 24, small study size, but that's just a gut thing I do. So no more questions? Compact stack is important, but all honestly, yes, they are important. I have to scroll up here. Difference in
So,
outcome are
I
trials.
put on the link, Thomas, for that's a Delphi that we were involved with for regional anesthesia core outcome. So there's a core outcome set of measurements for regional anesthesia trials, and they do include morphine in recovery. So it's just something to look at.
Yes, thank you. Thank you.
And I agree with your dexamethasone. I quite like to give bigger doses as well. There's a study that Henrik Kellett was involved in, which is, I reviewed it for the BGA. It's amazing. They give a milligram per kilogram of dexamethasones. They give 70 to 90 sort of milligrams or so of dexamethasone, which I thought was, wild, but it's for high pain responders, and they've done it for total knee arthroplasty, and it makes a difference in those high pain responders, which I can't remember the exact definition, but people who are at higher risk of pain.
Yeah, yeah.
And they did it for hips, but interestingly, there was no difference in the hips with the big dose. But it's a paper, you should read them in the BGA.
Yeah.
I'm just meaning for the
Two
audience,
papers.
it's very interesting.
It was a series. They had 2 papers on this thought.
Yeah. Okay, so will I hand over then? We've got 20 minutes or so left, just under 20 minutes. I'm going to introduce Dr. Fanny Alevro-Gianni. She's the Esra board representative for the trainees and residents all over Esra. So she works in Greece, but is chair of the residents committee for Esra, and as I say, sits on our board. So she's going to do a case presentation on a spinal hematoma. And any questions, as I say, put them in the chat and we'll discuss them at the end. So thanks, Fanny.
Thank you very much, Alan, for the kind introduction. Congratulations to Peter, and I'm very happy that we're doing this first session together, and heartfelt thanks to both you and Thomas for supporting our initiative. So in the next couple of minutes, I will be presenting a clinical case of a spinal epidural hematoma after multiple attempts for spinal anesthesia. So about our patient, our clinical case is about an 85-year-old female patient who was admitted to the orthopedics department due to a right medial malleolus fracture, as you can see in the X-ray. Past medical history of relevance included actually lumbar stenosis, although without neurological symptoms, and she was a heavy smoker. On physical examination, she was found overweight, and regarding her orthopedics problem, she presented with reduced mobility of the ankle joint, severe swelling, and blisters both on the medial and external side of the fracture. Laboratory tests revealed no significant results. So because of the blisters, the patient was admitted and decided to be treated first conservatively with antibiotics for 7 days. Thromboprophylaxis was commenced on admission, and after she completed with the antibiotic scheme on the 21st of October, it was decided she undergoes surgery for open reduction and internal fixation of her fracture. So here we would like your input. Given the patient's profile, which anesthesia technique you would choose, either spinal, general, or epidural anesthesia. And I really hope we get some answers so we know how you think. So 75% of you thought to do a spinal, and actually this was our plan. So late at night on the 21st of October, we placed our patient in the lateral decubitus position. We used a 23 Gauss needle and did actually multiple approaches on the L4, L5 level. Though after multiple unsuccessful attempts, we converted our anesthesia care plan to a general anesthesia. Second question for you. What is the main thing? What would you fear the most after multiple spinal attempts? The infection, the spinal epidural hematoma, or doing a nerve injury? Okay, so 50% for spinal hematoma and around 40% for a nerve injury. So for the surgical day, our operation was completed uneventfully and the patient returned to the ward around midnight. She did not need any transfusion perioperatively, and thromboprophylaxis was commenced 18 hours postoperatively, and you can see the exact timeline next to the clock. So on the second post-operative day, in the morning examination during the ward rounds, the patient presented with progressively worsening weakness of lower limbs and weakness of dorsiflexion of the foot bilaterally. Laboratory findings had no indications of hemorrhage or coagulation disorders, neither in physical examination. So we went on with doing a thorough neurological examination, and most muscle groups in the lower limb had deficits, like just palpable contractions and also impaired sensation of both limbs at the level below the knee bilaterally. So another question for you. What would be the most likely diagnosis for you at this point? A spinal cord ischemia, an ischemic stroke for the patient, new onset of neuropathy, or a spinal epidural hematoma? Okay, maybe we agree. And as also we thought about the spinal epidural hematoma, we continued the workup. And what would you ask first? Would you call the neurologist for a consult, or would you do a CT scan or an MRI scan? So this is how we also proceeded, and luckily enough, we're a major trauma center and we have an MRI, a laboratory 24 hours in the hospital, and the MRI scan revealed the spinal epidural hematoma compressing at the level of L1 vertebral body. So on the same day post-op, around 6 hours later, our patient was operated under general anesthesia, and the surgeons did the surgical drainage of hematoma and spinal cord decompression. Immediately post-operatively, the patient showed some signs of neurological improvement. She returned again to the ward, and 7 days post-operatively, she started her new rehabilitation protocol. 3 months after, she was discharged from the hospital, and she was then able to stand alone and walk with help. So moving on to the discussion part regarding our clinical case, we know according to literature that spinal epidural hematomas can be rare but potential devastating complications related to regional anesthesia. Even though there is low incidence of symptomatic cases, less than 1% of all spinal space occupying lesions, the incidence after neuraxial anesthesia, they're approximated to be less than 1 in 200,000 spinals. Risk factors, you can see them presented in the slide, but actually what of them were related to our patient included the advanced stage, the female sex, the traumatic and multiple puncture attempts, and the lumbar stenosis. Remember that thromboprophylaxis was stopped at least 12 hours before, and there was no need for transfusion perioperatively, nor deficits in the laboratory testings perioperatively. About clinical manifestations, actually the presentation is consistent with the distribution of the respective neurotome involved because of the pressure to the spinal cord. Most of cases, they manifest early with acute low back pain that is related to progressive muscle weakness and maybe sensory deficits. And moreover, depending on the level of hematoma, urinary or fecal incontinence may also occur. So the American Spine Injury Association created this flow chart that you can see in the slide so that we can objectively write down the deficits related to spinal injury that our patients present. On the right part of the slide, you can see there is different grading for muscle dysfunction and sensory deficits, and there are some cases when you should seek for non-key muscles. And on the last part, they give you also a stepwise classification on what should be our next step in the workup. So every time there is a return of motor or sensory disorder after the withdrawal of the neuraxonal blockade, we should have a high suspicion of an epidural hematoma, and we should continue with an immediate investigation. Our patient needs a thorough neurological examination to record the neurological signs. However, we should not wait more time until he does an MRI scan, which is the diagnostic imaging modality of choice, and alternatively a CT scan. So for MRI findings, the majority of hematomas appear around 36 to 48 hours after our procedure. MRI has also the potential to highlight chronological characteristics that are different depending on the hours of the onset of the case. Esra has also published a flowchart regarding which patients should be of high level suspicion for spinal epidural hematomas, and these include the return of blockade more than 1 hour after the block resolution, or last epidural dose given more than 3 hours ago, difficult epidural or spinal placement, focal neurological deficit or deficit in the absence of the expected level of the blockade, back pain aggravated by palpation or by Valsalva maneuvers, a patient in distress, or abnormal findings for coagulation. However, literature agrees that we should do an urgent surgical decompression. Our patient has to go to surgery to drain the hematoma. Patients are rarely treated conservatively, and the overall mortality rate is around 8%. However, there's no consensus still in the time interval to fully agree. There are some studies that have revealed that the optimal window for surgical treatment should be from 8 to 36 hours in the presence of paralysis, a bit more bigger, 12 to 48 hours if there are only movement disorders. However, if we go in surgery into the first 6 hours after the neurological deficit for surgical decompression, it's associated with improved neurological outcome. And though it's not relevant with our patient because her spinal hematoma probably was not due to the antithrombotic therapies, he was on only thromboprophylaxis that was both stopped and commenced in correct intervals. For the first time, ASRA and Esra guidelines, they're in full agreement. Actually, I wanted to highlight some of these points that we should not be afraid if we see during the needle puncture or the catheter placement blood, and we should not necessarily postpone the surgery. What we should do is to have a good cooperation with our surgeon and initiate the low molecular weight heparin 24 hours post-operatively. If this is not the case, after needle placement, the needle placement should occur at least 12 hours after the low molecular weight heparin, and our patients post-operatively are preferably put in a single daily dose of heparin. So to conclude, we should be alert for the possibility of a spinal epidural hematoma in the post-operative period, especially if we have a neuraxial blockade with multiple attempts or if we have a patient on antithrombotics. The MRI scan still is the gold standard of the diagnosis, and early surgical intervention is associated with optimal neurological outcomes. So, thank you very much.
Thanks, Fanny, for a great presentation. I haven't seen any questions yet. If anyone's got any questions, put them in the chat. We've got 3 minutes left. Normally we could stay on a bit late, but Faye, Thomas and me have got to rush off to another Esra council meeting. So, so a couple of minutes. Thomas, have you got any questions, or will I ask one to? Faye, can I ask, do you?
Just some.
On you go, Tom. On you go, Thomas.
There's some standards that pop up into my mind of own experience. These curious things, because if you read texts about how to see patients, what makes you suspicious? The trigger to become kind of effective and ordering an MRI, that is so critical. It's like sepsis. If somebody speaks it out, okay, you have the standards that come into place. And it is similar when you come from the level of suspicion into activity. And I remember a case where we did, I think, an epidural Friday in the afternoon. And Sunday morning, during a ward round, this patient had a bladder catheter. But, you know, a new bladder catheter typically doesn't mean anything. Many of our patients have bladder catheters. But once you've asked yourself, is that a standard or not? Why did the patient all of a sudden have a bladder catheter? And that was key of a component to look a little bit deeper into this lady that typically doesn't need a bladder catheter, because you have your standards bladder catheter, and that is meant by these hidden words of I do not know which slide it covered, that people can't hold the feces, can't hold control the bladder, but to have a real experience of it and not forget about it. I think these are components that pictures in your mind can be spread and maybe add a little bit of a story to to what you've told us.
I know. I think Faye's quite sort of nicely shown the key point is we have to be aware of these complications, and early diagnosis and early intervention is key, isn't it? That's what we have to do. And certainly in the UK, we don't follow our patients up, I don't think, routinely as well as we could. So we don't see necessarily everyone after a spinal anaesthetic to check that they're okay. The obstetric anaesthetists, they're very good at doing it. They all mostly see their patients afterwards, but in the general side of things, we don't always, I think, follow our patients up as well as we could. And fortunately, this isn't a common problem, but still, maybe we could be following our patients up better to pick up these complications earlier. Anyway, we're at 7 o'clock, and I think we probably have to go, I'm afraid. So I just want to thank again Peter, Thomas, and Fanny, especially for helping bring this all together. So the residents, the Esra Residents Committee, for the first webinar. I hope it was useful for people. And when's the next one? Faye, have we got a date yet? Or
We were aiming for December, so we have 3 extra trainees journal club during the year. But
good.
we will have more information about that soon, and I'm very happy that we had lots of participants thanks to your help, actually.
Okay, so well, thank you again, everyone, for joining us, and we'll hopefully see you all in December.
No, in September.
Well, we'll see. Yeah, we'll see you in September 1st, hopefully in
Of
Oslo.
course.
I'm thinking for the next webinar, but of course, yeah, hopefully see as many of you as possible in Oslo first of all. So, right, bye bye.
Take
See
care.
you in Oslo.
Goodbye.